I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
Welcome to this episode of IDD Health Matters. Today we took a road trip and went out to, where are we, Nashville?
Hermitage, technically
Hermitage, that's what I was thinking. We're just outside of Nashville to visit with a friend and a guy who's doing some amazing work in this field, Matt Holder, Dr. Matt Holder with Kramer Davis Health. Welcome, Matt.
Yes, sir. Thank you.
So tell us first, what is Kramer Davis Health?
Well, Kramer Davis Health is an organization that we launched a couple of years ago. It's an outcropping of the experience that we had building the Lee Specialty Clinic many years ago in Louisville, Kentucky, and operating that. It's an organization that the entire purpose of it is to provide care to adults with intellectual and developmental disabilities, outpatient healthcare, and I'm going to call it transdisciplinary outpatient healthcare. And so what that looks like is in this building, we provide medical, dental, PTOT speech, behavioral, psychiatric, other specialty types of care, all coordinated under one roof, where each of those clinicians and practitioners are interacting with the others on a daily basis. They work together as a team to provide care to patients with IDD. When you look at it as a whole, not only are we providing great health care to the individuals that come here, but we're also providing it in a better and more efficient way that is beneficial to the overall system of healthcare. And one other thing I want to say about Kramer Davis Healthcare, which I think is important, is who we're named after before we go into all the technicals of what we do and how it's beneficial, but just who it's named after, because we really wanted to get across our orientation, which is always very staunchly pro-patient. Everything that we do is for the patient, to the point where we'll say things like, I don't care if we get paid for it or not, we're going to do it for the benefit of the patient.
And I know you and you will.
Absolutely. We do it a lot. And anyway, our name is after two of our patients originally. Of course, we have permission. They are now owners of the company, so they're out there in public. But Trey Kramer and Terrence Davis were two of our, I call them our most instructive patients. They were very amazing individuals, lots of interesting things going on with them. And we've spent a lot of time with them and their families, developed great relationships with them, but they really helped us learn how to provide this transdisciplinary healthcare. So we wanted to honor them, and we also wanted to make sure that anybody who came to our clinic knew that that was our orientation.
All right, so they're patients from the Lee Specialty Clinic in Kentucky, right?
That's right.
Okay, so tell us about the journey from the Kentucky clinic to Kramer Davis here in the Nashville area.
Oh boy. You know, in this field, nothing happens quickly. I'll just start with that. We're under-resourced. Nobody knows what we're doing. IDD is like a mystery to most people who aren't in the field. And so any new idea, is just sort of met with a lot of like puzzling stares and questions like, really, you want to do that? Why would you want to do that? However, the people who are in the business, when they start to see some innovation, people get excited about it. So for us, when we launched the Lee Specialty Clinic, with the help of the state of Kentucky, we launched that clinic, and there was immediate kind of national buzz. Actually, we got published in the New York Times. There's a lot of media around it.
Yeah, you and I we spoke at a conference in North Carolina. You came and spoke about the Lee Specialty Clinic.
Yes.
When y'all were ramping up. This was when
this is like 10 years ago.
Yeah, somewhere around there.
Yeah.
And I was talking about things I was doing in Mississippi.
That's right.
So I remember that from back then.
Exactly.
Yeah, it's innovative, and people were interested and wanted to learn about it.
Exactly right.
Yeah.
And so it wasn't shortly after we opened that apparently word had gotten out in Tennessee that we were open. And so Tennessee decided to send a whole delegation, and I'm saying like 20 people or so came up. So these were high-level folks from the insurance companies here in the state, and from the government, from DIDD, from the TennCare, from just different agencies. So it was a big group of people who came, and we gave them a big tour. We spent the whole day just kind of talking about what all this was. Now, we had a particular model of how we got this done in Kentucky, and that relied heavily on the state government of Kentucky sort of helping make up the difference between what it costs us to deliver the care and what insurance actually pays for the care.
I want to come back to that point a little bit later, but go on.
Okay.
Don't let me forget.
Yeah, it's crucial.
Yeah.
And so that's actually been one of the biggest challenges in spreading this model out to the different states, is just figuring out how are you going to pay for the ongoing operations. So it took probably 2 or 3 years of discussions with various people here in Tennessee just to kind of figure out what that might even look like. How do you even get started? What's the risk that you're taking as an organization? And, this is IDD. We don't have multiple millions of dollars to throw around to just take a risk on something that may or may not work out.
Right.
That's the unfortunate reality of trying to figure out, the business side of all this. So we started to, we had a little bit of a foray into Tennessee, almost opened the clinic, and then we got kind of stuck on just some of the machinations of what I was saying, like the risk and everything you have to get into. And then the pandemic hit.
Yeah.
And so that kind of threw a few things off. Well, ultimately we figured it out. We figured out how to get everything built, and we had a great partner with Blue Care of Tennessee, Blue Cross Blue Shield. And I mean, they're a payer, but they were so committed to helping us enter the state, understand the payer environment, and they really included us in a way that very few payer entities have included us, but they really included us in the research side and the business research side to get all this to work. So ultimately, that's what it took. It wasn't the passion, because the passion's there. The need is there. We have tons of families here, just like anywhere else, who want it and who need it, but we had to figure out the business side of it. And that was, once we figured that out, then we were off and running. And even then, it took us 2 years from the time we said, this is the place we're going to build it, to the time where we said, now it's open.
Well, it's no small feat opening any type of clinic, and then you're looking at a specialty multidisciplinary clinic, and there's a lot that goes into that. I mean, we were talking a little bit about this earlier, just the electronic health record system.
Yes.
And documentation and how things need to be documented, and having an integrated system to support people who provide integrated care. You don't want just a dental documentation system and just a medical documentation system. You need something that works together. And there's lots of challenges in building things like that.
There absolutely is.
Going back to the point I mentioned earlier, and financing and having partners and the importance of that, you mentioned how there's sometimes a gap between maybe what payers pay for certain services and what actually is required to perform that service. And that gap can be fairly significant when you're talking about healthcare for people with intellectual and developmental disabilities.
Yeah.
What are some of the reasons that it's more challenging or more costly?
Yeah. This is really an interesting, that's a great question. Because a lot of times when I encounter payers, governments, I've had lots of conversations, national, state governments, about the IDD population. Especially I think for people who aren't in the field, they kind of tend to just look at this and think, okay, IDD, everybody in IDD is kind of the same. And if we just sort of target to the average person with IDD, that somehow it's all going to work out. That I don't think is the case. You have this, as we know, everything's a spectrum, and there's not very complex and there's very complex. And I think that the solutions that you have to have in order to work with each end of that spectrum are wildly different. I'm of the opinion that the majority of people, probably the vast majority of people with IDD, can and probably should get their health care just out there in the rest of the system with probably just a little bit of education and a little bit of tweaking of your average practitioner, probably they're going to do okay, and that's fine. However, I think that there's 30% or so of the IDD population where their cases are so complex that now you're starting to need this kind of care that we provide.
Speaking to that, you hear different thoughts, and one thought is that everyone with any level of disability should be able to go to any clinician's office. And I say this a lot as kind of a goal. They should be able to go to any clinician's office and get a basic level of competent and compassionate healthcare. And that really is the goal.
Yep.
And I think most people would agree to that. Mm-hmm. But just like if you have a significant heart problem, you're going to go see a specialist. You're going to go see a cardiologist. Or a significant stomach problem, you're going to go to the specialist. And that there's a place for specialty clinics in the way I see things as well too. When you need that a little higher level of expertise to address some challenging problems sometimes.
Yep, that's exactly it. Yeah. And I think that when you start to tackle, kind of going back to your original question, when you start to tackle how you're systemically going to address those issues, it requires sort of different solutions and being able to integrate those solutions. So we don't want, a bunch of specialty clinics going up where that's the only place people with IDD can go. That goes counter to the whole social inclusion movement and all of those things. But you also don't want to force those same people to go to underprepared clinicians and underprepared offices to get terrible care and then end up in the ICUs and in the emergency rooms and over-medicated, because that's what's happening now.
Over-medicated, all kinds of tests being ordered that don't necessarily need to be, or no tests being ordered and people just put on medications, or lots of less than optimal healthcare situations.
And that is, I think, the crux. Going to the business side of this again, I hate to keep going to it, but that's been my world for the last couple of years, is like trying to translate all of the good, like heartfelt work into dollars and cents argument.
Yeah, and you've got to be able to pay people to do this work.
Yeah, but here's where I'm with this. I believe, at least in my world of transdisciplinary healthcare, and again, the people that come to our clinic tend to be in the very complex end of the spectrum, because that's who benefits the most from what we do. But we're at a place where, especially those individuals, the cost that, I'm not even going to say the cost, what we're spending to provide them with suboptimal care is kind of ridiculous. We're spending
currently the system as a whole.
The system, not us in the clinic, but just the system as a whole. You're talking, it could be 5-10 times as much on a per capita basis,
and the outcomes are
terrible,
subpar, and
the outcomes are awful. And so where the true opportunity is to help train the healthcare system to understand, if we do this in a better way, in a more coordinated fashion, in a more preventive way, then the money that is spent will actually be less. Like, you'll save money and have significantly better outcomes if you do this right. But part of doing it right means you're focusing on the right part of the spectrum. You can't do this for the entire group. It actually wouldn't be cost effective to do it that way. So we really have to get very nuanced in the way that we're systemically delivering healthcare. And what I always tell people is, when you come to this clinic, we're like a tailor shop. We're going to build you a suit from scratch that it just fits you, because we are, that's our orientation. We design our healthcare approach to the specific needs of the individual.
So speaking to that, tell us about some of the tailors you have in the shop. What are the different disciplines that you have here at Kramer Davis Health?
Yeah. So we've got primary care medicine, which actually I'm going to call it developmental medicine. You and I are both certified, so I believe it's a specialty of medicine, or at least certainly an area of interest that people should spend more time in. Mm-hmm. So I'm going to call it developmental medicine, but we can also call it primary care for the uninitiated. The same thing with dentistry. So we have dentistry as well, but you can call it developmental dentistry if you want, because that's all we do. In addition to that, physical therapy, occupational therapy, speech therapy, psychiatric care, BCBA, so behavioral analysis as well as we need it. And the way that let me touch on behavioral just for a second, because the way that we use behavioral interventions here is as a means of helping people get through the visit at the clinic. Keep in mind, a lot of our folks that come to us have been, what's the nicest way to say kicked out, but they've been kicked out of a lot of other practices.
Had some probably pretty traumatic
Bad experiences. Absolutely. Yeah. And because of behaviors, because of maybe not understanding how to get through the visit or what's going on, or who knows, but we take the extra step of having a behavior analyst who can help sort of break that visit down. So, and again, this is the kind of thing that takes a lot of time. Sure. That you don't get paid for. Right. But we have people who on their first visit to the clinic can't or won't get from the car to the front door of the clinic. Like, we have to start there. And then, okay, now the next step, just the next increment is, okay, front door to the front desk. Next increment, front desk to the waiting room, waiting room to the exam room, allowing somebody to do an exam. I mean, like, you have to break that down sometimes, and that might take 10 visits before you're actually able to deliver the thing you're supposed to deliver. And here's the thing, in our practice, if you're willing to accept that is a possible pathway to have a successful visit, it completely changes your orientation on what you're going to do as a doc. Because if you don't have that orientation and you don't even know that you can do that and be successful at it, then the trick that you reach for as a clinician who doesn't know is, well, gee, that just seems like they're really anxious. Why don't I just give them a benzodiazepine? Let's start a new med. Yeah, they'll be gorked out when they come to us, but I can get the exam. I'm get them through the exam. Well, but that's not good for the patient.
Yeah, not at all. So that was what you described was something we often hear called desensitization, or maybe acclimation to a different process. You mentioned something else in our chat earlier about kind of people who have always had to have a higher level of care, such as being in having to have general anesthesia for dental visits, or maybe having to be restrained to have dental visits. And you've had some success kind of going the other way as well, right? So talk about that a little bit?
Absolutely. So, the success has been pretty good. So just a couple of numbers. I know from our experience, there are a lot of patients who, starting off at the age of their first dental visit, the dentist said, you know what, we're going to have to do this under general anesthesia. They don't understand what's happening. They're too difficult to manage in the chair. So we're going to have to do this under general anesthesia. And from that moment forward, every single year for the rest of their life, they have gotten general anesthesia for routine dental care, not complex dental care, just routine. It could just be dental cleanings at that point. And that is a pretty heavy hammer to throw down on somebody, for something like routine dental care. So a large number of our patients come to us with that history. And I can't tell you how many times we've gotten somebody who's, 35 years old, and that's the story. And we just say, you know what, let's just not do that. Let's put them in our dental chair and just see how they do. And we don't have to do anything. I mean, they're just fully ready to do it. It's just, that's what they've always done. That's just what they've been told their entire life. Yeah. It's just the assumption always been made. Now, that's not always the case. Sometimes there's, there are behaviors, and there's, and I just look at it as, look, this person's never had the opportunity to sit in that chair and figure out what's going on. So they don't know what's happening.
Never had the maybe the support of of an integrated staff with, psychologists and behavior analysts that can understand the context of the behaviors and maybe make some adjustments that can make everything go better.
Exactly. And that's what they do. And so, and again, that might take one visit, it might take 12 visits, who knows? But 93% of the time, we can successfully get somebody out of the operating room, out of that general anesthesia hammer, and we can get them into something that is significantly less than that. And, maybe it's a weighted blanket or something like that. Who knows? But we always have a plan of trying to get them from general anesthesia to hopefully nothing, so they can just get through any old dental visit. And then at that point, they may not even need to come here anymore. They might be able to transition to some other dentist that's closer to home. Great. If that happens, we've succeeded. So that's part of the whole transdisciplinary approach, though, is you don't see behavior analysts sort of roaming around your average dental office, you know?
No.
But, you know, having that transdisciplinary communication, that just helps the whole team kind of figure out, all right, how are we going to do this?
And you've had pretty good success with that.
93%.
93%.
Yeah. Yeah.
That's impressive.
Yeah. And so we'll probably publish some numbers here in the next year or two. You know, we're still kind of perfecting it and refining it. The funny thing is we've been doing this for probably 10 years. And every year we say, oh, we'll publish it at some point. You know, the hard part is sometimes you're just too busy doing it to write it out and tell people how you're doing it, you know? So thankfully we have a podcast where we can talk about it.
There we go. So I always like to talk about the person. So Matt, how did you get into this field? All right. You went to medical school.
Yeah.
Start from there.
Okay.
Or maybe before, if you've had earlier influences.
No. So that's the funny thing. I had almost no experiences with people with IDD growing up. I
didn't either.
I had a next door neighbor whose name was Alex, who he lived behind us, and we would sort of like kick the soccer ball back and forth. And Alex had Down syndrome, and so I'd like go over to his house with his brother, and we'd play like Atari or something, back in the Atari days. And that was probably the only exposure. And I never actually had no idea there was anything different about it. I never thought about it.
Yeah.
Oddly enough, but that was probably like the only experience that I had. Fast forward all the way to medical school, had one lecture on Prader-Willi syndrome where we had a mother and a 10-year-old boy with Prader-Willi come. And it was frankly probably the most memorable and fun medical school lecture that we ever had.
That was more than I got.
It was more, and it's more than most people got. What I got was actually average, 1 hour. But there's a whole bunch that get less than that, which is terrible. But it was very memorable for me. But again, that didn't really influence I wasn't there yet. I got out of school, got out of training, and now, fast forward a number of years of medical experience, and I've been in the system, and I've kind of seen kind of what it's like. And so my stepfather, who I've been in business with for a long time, who helped me launch all of this clinic. I mean, we're partners, and we've done this together for years. He was a dentist who worked with people with IDD. So he was actually the one that pulled me into all this. Now I'm getting out of training, and I'm just kind of bored with the regular practice of internal medicine. I've kind of felt like I felt like I could do more in the healthcare space than just handing out like cholesterol pills and,
Understood.
insulin, and that kind of thing. So he started to tell me about the IDD population. This is back in 2002 now, right? And he started telling me about this population and how there's this need, and nobody nobody knew about them. I'm like, yeah, I guess nobody knows about them because I just got out of training and I don't know anything. And I had a couple of conversations with some early people, Steve Eidelman, Tim Shriver from Special Olympics, sort of some Dr. Phil May, who helped found the ADMD. Yep. Early on, and I just thought, this is really interesting. This is kind of like why I went to medical school, to help people, but like in a kind of a very, I don't know, wholesome way, I guess, or a holistic way. And I don't know, it was just really just felt like the right thing for me. So I just said, you know what, I'll just give this a try. Now I got into the rude awakening of a physician entering into the field of IDD. That was a whole different thing of, keep in mind, like those are the days when, community integration was like at its peak, and we were like jettisoning the medical model and all of that. And so, I'm trying to like get into the field, and people are like, oh, you're a physician, you're part of the medical model. I'm like, I don't even know what that is. Yeah. What am I coming into this with, and I found that fascinating too. Just that whole, like, how do you navigate that? And I don't feel like I'm a terrible person. Like, I'm just trying to provide good care,
I think that misconception is still present in a lot of ways. Sometimes if you speak about healthcare at all, people say, oh, that's the medical model. Right. We don't do that. I'm like, so you don't want people to have equal access to good health care.
Right.
That's not the medical model.
Right.
That's health equity.
Right. Exactly.
That's inclusive health. That's what we want, and that's what we're working towards. So we still have to dispel that medical model mindset every once in a while.
And I think that a lot of progress has been made in that regard, right? Because I think, and back when I was first coming on, like the folks who were making things happen in the field were, that was the fight they were having. I think what happened was they won the fight. I mean, they opened up community integration and it was a great thing, but the assumption was Medicaid would be enough. There's docs out there,
That assumption, and the assumption was that people will go out and find community doctors, and the doctors would completely know what to do.
Yeah.
And are capable of providing health care, when we both know how little training most of the other people we know have received in this field.
I think it's the technical nature of medicine. It's sort of like your car mechanic. Like, I take my car into the car. I don't know if he's a good car mechanic or not. Like my car comes back and it works, I'm okay. But I don't know everything that person knows, that level of technical understanding.
Yeah, no, you're right.
So I think there was just this understanding like, they went to medical school, so surely they've got a technical level of understanding that will make this work. Anyway, so for me, it was just that challenge was really fascinating for me. I started working with Special Olympics. I became their global medical advisor for 16 years. Had some really cool international experiences talking with lots of like world leaders and people trying to make their system in their own country better for people with IDD. And that really opened up my eyes too, just internationally. You think things are bad here, and then you go other places and you realize, wow, like it's actually not that, like we're really trying to improve the system and we complain a lot, but I've seen much worse.
Yeah.
And the other thing too, is I've seen also much better with significantly fewer resources, which is also an interesting whole different conversation. But all of that sort of brought me into it. I got into the AEDMD and really got into the idea of teaching people about this. And then just sort of all of those experiences snowballed and kind of self-perpetuated. And here we are today. Here we are trying to change the world.
So you fit in kind of the second category of the way people come into this field, in my experience.
Yes.
One is they know someone, they have a family member, they're touched by it in their personal lives, which is not the way I came in, or you, it sounds like.
Yeah.
And the other is you just kind of fell into it.
Yeah.
And you realize this is where I need to be.
Yeah.
And this is the place I need to be in doing this. And that's kind of what happened with me as well.
Yeah.
Yeah.
It feels right. I don't know whether it's a moral thing. I was always the guy that would kind of like stick up for I'm a big guy, I'm 6'2", I'm 200 something pounds, at some point, but I was always the guy that would like stick up for the kid getting bullied on the playground, like that was my kind of thing. And so I don't know if that's a personality thing or what, I don't know.
Yeah. And I see it as a field that really needs, let's just say it this way, that there's room for growth and room for improvement, and there's room for creativity, and there's room for developing new things and new processes to make it better. That's what I like.
That is exciting.
It's very exciting. It's like this field, could benefit from some new thoughts and ideas and growth, and how do we make all of this work? And that's very stimulating for me, and it sounds like for you too.
Absolutely. It's a wide open field. I think that's what makes it so exciting, is it's a wide open field. There is still there's so much opportunity here, especially if we are successful in showing the system a better way to do it. Like at some point there will be an influx of people who have in their back of their mind wanted to get into this, but just didn't quite know how. But once it becomes a more viable career path for people, I think we're going to get, there's a lot of people that will follow that passion.
And you said viable career path. And that's one of the reasons I'm doing this podcast, is to help people see this field as a viable career path in whatever area, whether it's, healthcare, medicine, direct support professionals, administration. And we've talked with people from all different walks of life. And this can be a very rewarding field absolutely. To work in, for sure.
It absolutely is. It's something for me that it hits all the right chords for me. And again, if you are creative, if you're entrepreneurial, sure, it's a great place. There's all kinds of innovation that can and needs to happen.
It needs to happen. Yeah, that's the other part of it.
Yeah, or if you just love working with people, if you just, love, if part of, like, I can tell you, one of the amazing currencies that you get paid in this field is, it's not money. It is just the amazing appreciation that you get. I will tell you, every week, and in this clinic, probably every day, we have a new parent that comes in and literally will be in tears because they've never experienced anything like, they've never been in a place where their loved one was so just immediately accepted. And it doesn't matter what happens, if it doesn't matter what they look like, what they act like we're going to ask them to come back. Yeah. And they haven't experienced that kind of acceptance. And that's something that you can't put a price tag on, that kind of job satisfaction, if you will,
No, so people can have that experience here in the Nashville area now.
Yes.
They've been able to have that in the Louisville area with Lee Specialty Clinic.
Yeah.
Anything on the horizon?
Yeah, well, so we're constantly looking. We're scanning the environment. So here's the thing: it's so complex as to figure out where to go next. So,
and it's kind of different in each
everywhere you go. It's completely different.
Yeah.
Without getting into a really dry discussion about the complexities of the insurance world, because that really is what is. I'm going to say it's an impediment, quite honestly, to a national level of progress. Is right now, the majority of these individuals are on Medicaid, but you know what? Who doesn't want to take Medicaid? Like, most health systems, most healthcare providers just don't even want to mess with it. Yeah. So we've got to figure out how to make this, work. You've got insurance companies, and if you go into one state, maybe you have to deal with 3 insurance companies. You go to a different state, you're dealing with 15 insurance companies. Well, if I have to sit down and negotiate, and trust me, negotiating with insurance companies is not fun. It can be difficult, but if I have to sit down with 15 of them just to open a clinic that will focus on this population, like, that's going to take a long time, and that's really hard. So what we have to do is we've got to work, I think, at the national level, coalesce all the data, and now I'm talking just economic data that shows that the quality is better and the cost is at least neutral or better. And I think once we can prove that case, I think that it should be a no-brainer at that point from the national level and from the insurance payers, just to say, you know what, like, why wouldn't we do this? This makes all the sense in the world. So I think that we're kind of on the cusp of that. Might be a couple of years before we can prove all that out, but that's what we're here for.
And then we'll see where we have more Kramer Davis clinics.
Yeah, that's right. Yeah.
Friends for Life Residential Care, specializing in support for individuals with developmental disabilities, offers services like adult day support and home health care. Emphasizing empowerment and quality of life, we live by the motto, "My ability is stronger than my disability." We are currently hiring, welcoming those passionate about making a difference. Learn more and explore career opportunities at friendsforliferc.com.
I'm Dr. Craig Escude, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support.
So, Matt, one of the things I like to do on the show is something I call 3 in 3. It's 3 things in 3 minutes. 3 tips, 3 words of wisdom, 3 pieces of advice for listeners that you think can help improve health and wellness or the general world of services and supports for people with intellectual and developmental disabilities?
All right. I'll start with, I think the first one for me is probably the most important, and that is kind of a combination of advocacy and determination. What I have found out in this field, I kind of started with this a little bit earlier, is saying that most people don't know about this. And so you will frequently get doors closed in your face just by default because it's too much for somebody to think about. You can't let that happen. You have to fight. But you have to do it in a compassionate way. It's not, an aggressive way. You have to do this in a well-centered way that keeps the benefit of people with IDD in the forefront of what you're doing. This is why I'm continuing to have this conversation with you, because this outcome is unacceptable. So, I think advocating and tapping into that, being willing to have those conversations and not give up. That's a real important thing for being in this field, and I think pushing all the improvements forward. Apart from being an advocate, I think just always being very creative in the way that you look at problems. So the one thing, and I'll go back to the practice of medicine, we get people that are on all kinds of different drug regimens all the time. Now, there's an assumption that the doctor who did that knew what they were doing.
A good reason, and they needed it.
Right. And then but when you've been in this field for a while, what you realize is that may not really be true. And chances are
it may have been true for a short time.
For a while,
things
have changed.
But they stayed on the medicine forever.
Exactly. Yeah. And so you have to do that same type of analysis, but with systems as well, right? And really kind of look at, like, this is the way things have been done forever. So now I'm going to take that exact same mindset. I'm going to apply it to Medicaid, right? Medicaid pays a certain way for a certain kind of patient. And typically that's not our kind of patient. And the system wasn't designed for our kind of patient. And so, we have to look at that system and go, wait, the system was not designed with our kind of folks in mind. We now have to apply some creative thinking and not accept the status quo as it is, but apply that creative thinking to and create a better system, and can be able to convince other people that there is a better system that's possible. So I think the creative thinking part is truly important. And again, it goes hand in hand with the advocacy.
So you've got advocacy.
Yep.
You've got creative thinking.
Yep. And I think being centered on being person-centered, and being centered on the person with IDD, right? Because you're going to design that system around this person, and you should anyway. Yeah. If you don't, then you end up with a system that isn't designed for that person. So you always have to have this relentless sort of focus on the people that we're trying to benefit and the needs that they have. And every time somebody asks you to step into a different direction, or you're going to put a new plan into place or a new structure of some kind, you have to go back and
affect that person.
Yes,
as well.
You've got to go back and ask that question.
Yeah, and I think about that in terms of, we do in healthcare, we do a lot of things that's important for people, but it may not necessarily be the most important thing to them, or it may not work for them because it wasn't designed in the best way for them. So
exactly,
bringing them into the decision-making process to help guide the trajectory is one of the ways we can think about when we talk about person-centered.
Oh, absolutely. Yeah. Having that representation at the table is utterly important.
Yeah.
And in our world, making sure that you're continuously asking for feedback, monitoring to make sure that what you thought was going to happen actually happened, and that the person's life is better because of it.
And having the ability and the fortitude to make changes.
Yeah, absolutely.
When you have to.
Yeah. And admit that you're wrong.
Yeah.
Because that happens a lot. I can look back and there's a lot of things that I've tried that, hey, this sounds great. And then you go through it and you're like, that didn't work out so well. Well, okay, let's do that.
If we're honest, it happens to all of us.
Yeah,
so.
Right.
Well, Matt, it has been great learning about Kramer Davis and learning about Matt. And
Greg.
thank you so much for taking the time to sit down with me. And can we do this again some other point?
Absolutely. Maybe in Chicago at the AADMD meeting.
That would be great.
Yeah.
That'd be great. All right. Well, appreciate it.
Thanks, sir.